All right, we're live.
Okay, thank you. We're back from break. So Jen, I think what we should do is put the audio only language up. Then as we go through it, committee, you have raised issues that are important, and we've also heard issues from our various provider and payer groups. So what we'll do is we will take our time going through. Jen, you're going to probably share your screen, I hope.
Yep.
And then if someone has a question, raise your hand, because I have the list in front of me of who's raising their hand. And we can, if there's an interest in, from the committee, if the committee has a question, let me know, and we'll stop there. The one thing I do want to avoid are long speeches. We can make long speeches, but this isn't the time for that. So, and then we'll reach out to our friends on Zoom who are here with us to help debate or answer the questions. That's it. Okay, Jen, it's all yours.
Great. Jennifer Carby, Legislative Counsel. So this is, as you may recall, when we've gone through this language before, it was originally drafted as a committee bill in the House Healthcare Committee. So that's why it's formatted like this. And there is still some highlighting in here that shows changes that were made after that committee had worked as a group. And I worked with some other members as members of the committee leadership to make some changes. So just to preview for you why there is some highlighting in here. So the first section is in the health insurance statutes, and it is adding a new section in what is currently the subchapter called telemedicine, but I've renamed as telehealth. And this would be specific to coverage of healthcare services delivered by audio only telephone. We have a definition of healthcare provider that is the same or similar to definitions elsewhere in the statutes. And we have a definition of health insurance plan, which is any health insurance policy or health benefit plan offered by a health insurer, which is defined in Title 18 fairly broadly. Medicaid, to the extent permitted by the Centers for Medicare and Medicaid Services, and any other public health assistance program offered or administered by the state or by any subdivision or instrumentality of a state. It does not include policies or plans providing coverage for a specified disease or other limited benefit coverage. And I'll stop here just for a moment because I think there was some helpful discussion with Senator Cummings and others earlier about who is and who is not included in this definition. So as Senator Cummings had said, this includes the exchange plans, so the individual and small group plans, and the large group fully insured plans. It also includes Medicaid to the extent permitted by CMS. It doesn't talk about Medicare because we don't regulate Medicare. So for purposes of what we're looking through, we're talking about the commercial insurance market, not the self-funded plans, and unless they voluntarily choose to comply, and Medicaid to the extent permitted by the Centers for Medicare and Medicaid Services.
Okay, so, and then we did hear from Medicare, from DEVA, that as long as this language was in here, to the extent permitted, that they were fine. I have two hands up. I think I saw Senator Hookers went up first, and then Senator Hardy.
Thank you. Thank you. So what is permitted by Medicare? And it sounded to me when Senator Cummings was talking about it that this would be permitted through the end of the pandemic or the emergency orders, or, you know, what does that mean? So that if for instance, we want to extend the payments beyond the emergency order, then does that mean that if Medicare stops it at the end of an emergency order, that
We can't do it.
that would be the end of it for Medicare reimbursement?
So for Medicare is completely outside of the scope of what we're looking at because we have zero control over what Medicare does. It's entirely federal.
Yeah, okay. Medicaid.
For Medicaid, right. So for Medicaid is the ability of Medicaid to participate depends on what the federal government allows Medicaid to do. So we are attempting to include Medicaid to the extent possible. But if the federal government through the Centers for Medicare and Medicaid Services, CMS, changes what Medicaid is able to cover, then state law can't change that.
Okay, so that in the event that we pass this and we want our reimbursement to go beyond the end of the emergency order, whatever Medicaid is able to do based on what the feds say they can do will stop when that permission is no longer in play.
That's right. And really, it's not even dependent on whether Vermont is in a state of emergency necessarily or not. It's really, again, all dependent on what the federal government is permitting.
Right. So anything that's covered by Medicaid would no longer be covered, even if we pass this bill and other insurances are expected to cover the audio only.
Right.
Okay.
So this is really just recognizing the supremacy of the federal law in this area.
Thank you.
Okay. Senator Hardy.
Thank you, Madam Chair. My questions are similar to Senator Hooker's, but Jen, I'm wondering, especially for seniors, who's the group that we've heard could potentially benefit from this the most. Most of them would be covered by Medicare, I would assume. If they have secondary insurance, how does that play in? Is it possible that somebody has secondary insurance that might cover this if we were to pass this provision? Do you know how that works?
You're talking about
I don't. I think
supplemental.
that's
Yeah.
probably a better question for DFR, but typically the coverage parameters, or most of the coverage parameters under the Medicare supplemental plans, the Medigap plans themselves, are standardized nationally.
Okay.
But again, I think you'd be better to hear either from DFR, or I know I believe Blue Cross at least offers some Medicare supplement plans and may be able to weigh in on how this would affect them.
Okay. I guess I'm just trying to figure out if this would even help the people who we most want to help, which are seniors and low income people who have access issues.
So what, we don't know, and in our conversations with Diva, we just don't know whether or not this will be extended through Medicare, and I think that's an ongoing conversation. So there are a lot of areas here that are unknown. Any other questions on that first definition? Okay.
Let me get into the coverage requirements. So this requires a health insurance plan to provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio-only telephone to the same extent that the plan would cover the services if they were provided through in-person consultation. And services specifies that services covered under this subdivision include those that are covered when provided in the home by home health agencies.
Okay, so let's just stop here for a minute and let's try to understand exactly what is covered here. So Senator Cummings, you have a question, your hand is up.
No, I would say, I think this is probably the paragraph that is the stickler.
I think it's this one and the next one here, because the next one is really the reimbursement parity.
Right, yeah,
piece.
it's the parity rate.
Right, so this is coverage. Coverage has to be provided for all medically necessary, clinically appropriate services delivered by telephone to the same extent they'd be covered if they were provided through in-person consultation.
So-
And then the next part is the reimbursement.
The rate.
parity piece.
And I think that it's the rate. I don't think anyone is concerned about saying you have to provide something for audio only. The question is, do you have to in all circumstances, provide audio only at the same rate you would provide, at an in-office visit. And for those that haven't served on an insurance committee, we went through agony last year for those small employers, for the individuals with pre-existing conditions in the individual group, paying for that health insurance is painful. And any increase to the cost, causes employers to drop out. And so to me, the balance is trying to make sure we do the least, we don't drive people out of the insurance market altogether in trying to provide them better access. And I think that's the balance I'm trying.
So let's do this, Senator. Let's look at both 1 and 2 together, because it sounds like you're beginning to talk about that. So let's read through, Jen, let's read through B1 again, and then read through the next one again, so it's burned indelibly into our minds.
Okay, so B1 requires a health insurance plan to provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio-only telephone to the same extent that the plan would cover the services if they were provided through in-person consultation. And then we have this additional.
So let me ask this question. So just or a quick thought here. I'm sorry, I just violated my own rule. I interrupted the flow, but just a quick question. So if it were a phone call that we currently get about the follow-up surgical call, are your sutures hurt really in swelling or in pain or something that you would get ordinarily, that would not be reimbursed under this. This would, because that's not a regularly covered service. Who can answer that question for me?
Maybe the insurance companies.
Insurance companies or providers, because there are some, all right, keep going, Jen, because I've just moved into codes. I'm sorry, my fault.
Okay. So that was the coverage piece.
Yeah.
And then a health insurance plan shall provide the same reimbursement rate for services billed using equivalent procedure codes and modifiers, subject to the terms of the health insurance plan and provider contract, regardless of whether the service was provided through in-person consultation with a healthcare provider or by audio-only telephone. So B1 is really looking at kind of the patient experience of what is and is not covered. The second piece is looking at the provider experience of what they're getting, how they're getting paid, or what amount they're getting paid. And then just to remind us of what is here in the rest of it, the provisions of that reimbursement parity piece do not apply in the event that a health insurer and healthcare provider enter into a value-based contract for healthcare services that include audio-only telephone services. So if we're getting away from fee-for-service and looking at value-based pricing, then, or pay for performance stuff, then it could all get wrapped into an encounter rate or something, something different than just that straight reimbursement parity.
There's actually then an incentive to do that, I would think, but which is a good thing for me.
All right, so I'll go back up here. Yes.
Go ahead, Senator.
We just heard that some providers weren't doing audio-only medicine prior to the pandemic, and now they are. Audio has been there a long time. It's not a new technology. We've all had the 7 o'clock or the 10 o'clock at night call with the kid with an earache or croup or any of those good things. I've never been charged for that. We've heard that it might be in part figured into the fee that I pay for an office visit. Okay, in this, if I'm now going to get charged for the 7 a.m. pediatric, the kids got croup call, there's nothing that counterweights that says that that'll be removed from the office only. We've had a lot of calls to doctors in this house. I've actually taken photos of sutures and sent them in recently. According to my daughter, if she knew she was going to get hit with a $30 copay every time she called, she wouldn't have called. So I'm trying to figure out the cost to the consumer. Are parents with the kid with the earache now going to be charged for an office visit for the phone call that 6 months ago they didn't get charged anything for?
So I think it might be helpful to hear from particularly providers around the triage calls, because I think that's what you're talking about, is sort of the calls to determine whether an office visit is necessary. And it's my understanding that typically if an office visit is involved, that then there is not a charge for the triage call because it's sort of included in that office visit, which may be a telephone, I suppose, a telephone office visit. I think it would be good to hear from somebody who works.
Because I don't see anything in here that says, except for triage calls, or except when the call is included in the fee.
So some of that may get worked out in a later section that directs DFR and others to identify the codes to be used in various circumstances. But I think it would be, again, it would be probably helpful for you to hear from somebody who's not me on this.
I'm
just trying to figure out why we are set on requiring the same reimbursement rate as an office visit.
Let's throw a line out to a friend, because everybody here with us today is a friend. And I think Jessa Barnard, you're here. Why don't you, good, thanks, Jen. Why don't you help us with this one?
Good morning, Jessa Barnard with the Vermont Medical Society, and I will admit there are some limitations to my knowledge, but I will do my best. And Helen Laban with Bi-State, who is really a billing and coding more expert, had a conflict starting at 10. So I will do my best to fill in for Helen, which I think Jen Carby was getting at exactly what I was going to raise, the distinction between a triage phone call, the distinction between just I think there are actually three buckets. There are the buckets of I'm just calling to give you your test results. I'm calling to follow up on this image, which is not, my understanding is has not been and would continue to not be a reimbursable visit. Then there are triage calls, which are do I need to come in? I want to talk to an actual nurse or provider to screen for whether I need a follow-up visit. And those, even during the pandemic, have not been paid at parity, and there's been a waiver of copays. So patients have not been paying for those visits, and they are not paid at parity. I think they are actually it's a small reimbursement rate for those kind of triage, do you need to come in for a full visit call. The only visits that have been and would continue under this language to be paid at parity, it needs to be equivalent to a current CPT code. So there are standards for that. You need to provide a certain number of services. It needs to be a certain length. It really needs to be, you need to get the same type of care over the phone, if that's appropriate and possible, as you would in the office. And I also want to add the piece about patient consent and notice. So the provider would have to tell the patient. This should not be a surprise. Like maybe we've done the triage. Yes, you have an issue here. Let's talk more about this. And then they'd have to say, do you want to be, we could either do this over the phone and I will bill this and you may have a copay, or you could come into the office and we could continue this in the office. So I want to make it clear, we don't, we have heard some anecdotal stories of patients during the pandemic not being aware that this might happen and not wanting to pay the copay for a phone call, but that's why it's paired with the subsequent language about patient information and consent. So I hope, was that helpful?
But there's no documentation of that, right? We've been told that it can't be taped.
It would
and
not be
there's-
recorded, but they actually do need to document it in the
They
record.
need to write it.
Correct. But right, the whole visit will not be recorded and the consent wouldn't be.
No,
that
it's
recorded,
the
but-
consent part.
Correct. It does need to be documented. And actually the House, I think it was the House, or maybe it was actually your committee that asked for a copy of it to be offered to the patient as well, to make sure that if they wanted a copy, they would get that.
So, lost my train of thought. Did lose my train of thought. Oh, this is working on this is open to all practices, not just family care, and it's open to all patients. So I think there's a quality concern with, I can't see this patient now. I've never seen this patient. How do I know that this is, how's the doctor know this is medically appropriate?
So you're asking the question about the first encounter, or first visit with a physician, and that's later on in the language, is it not, Jen?
Okay.
Yes, that's coming up in the language.
I'll ask it later.
Yeah, so hold that and we'll get to it. But have your questions been answered regarding the types of audio only? So the triage, the follow-up, and then the
I'm just
equivalent
wondering
office
who makes that determination as to what
Jessa?
kind of, who's monitoring the doctors?
Well, I guess my response would be that it would be done the way billing is currently done, which is the provider would provide the service, document in the record how long it took, what was provided. Typically, that then goes to somebody in the back office who looks, okay, does it check all the boxes to meet a CPT, equivalent to an in-office visit or not? So it would basically be treated like any other modality of service, whether it was audio visual or an in-person. Does it, did they provide enough services to make this a billable visit or not? And there could be audits of that, just with, like with any other service, the payers can audit it. There's going to be data collected. So if there's some concern, all of a sudden we're seeing some huge surge in phone call only visits, that could certainly be something VPQ looked into, the payers looked into, and could audit a specific provider. Why are half of your visits phone only? That doesn't seem appropriate.
So, and let's ask this question, and then if it's answered later in the language, we'll hold it. But
I think I saw Sarah Teachow's hand up.
yeah, we'll get to her. My question is, and Sarah Hooker, Senator Hooker is first. The question I have is, later on in the bill, is there a provision for sort of as data is collected around audio only during this, what I consider to be data collection time? I'm not going to call it experimental time, but data collection time. Is there some process whereby a Green Mountain Care Board or other regulatory board is evaluating the numbers of audio calls? Maybe it's VPQHC, and maybe it's a complaint of the providers or the
Yes, there, I think you'll see,
payers.
and we can look at the specific language when we get there, but at the end where there is data collection and a report on data collection, it includes information on utilization, quality, patient satisfaction, things like that. It does specifically involve the Green Mountain Care Board and I believe VPQHC.
Okay, so we'll hold that thought for later, but okay. Let's go to Sarah Teachow, and then Senator Hooker, you have a question. Sarah, did you want to comment on this section?
Sure. So this is one of the things that Dr. Kate McIntosh was talking about yesterday, and she can't be here because she's administering COVID vaccines today. But She talked about the check-in or the follow-up call could slide into what's considered to be an office visit. And a lot of that depends on what's written in the medical record and then whoever's doing the coding and billing, how they do it. And so that may not be obvious at the time of the call. And so we expect that there will be some additional charges to patients and the system because of that. And then just to clarify on the triage calls, those are intended to be calls not necessarily with the provider, but with other staff in the office, to just say, these are quick check-ins, triage only. And so those are really distinct from the other calls that we're talking about. And that's why they don't have a copay in the law.
So I guess then the question is, suppose this language is put in place, then it would make sense that there's some kind of communication that goes out to providers, because I would think if there, as we just heard, if there's a significant increase in charges, especially to patients, without informed consent, there's going to be a little pushback on even having audio only. So I'm wondering whether there are any provisions in here for a communication or reaching out to, I guess would have to be providers, and part of the consent form might include something about this has been our practice for 30 years and we're continuing it, so that the follow-up calls that you're talking about weren't captured somehow. I'm just throwing some ideas out, but I think, if I were a provider, I probably wouldn't want to jeopardize the future of audio only by having too many follow-up lab report calls that I'm charging $30 for. Okay, so my opinion.
Right. So I think it's also helpful to remember that the coverage language is that these services must be covered to the same extent that they would be covered if they were provided through in-person consultation. So if they're telephone services that have always been telephone services and continue to be telephone services, then they may not be, there may not be any change even necessarily required under the statute that requires audio only services to be covered to the same extent they would be covered in person.
Okay, that's good. So
Yes,
Cheryl,
has a
Senator
question.
Hooker, you're muted. But do you want Jessa Barnard to respond first? I'm going to leave it in your hands. You let her know
Yes,
if you
please,
want to
Jessa,
hear
go
her
ahead.
first.
Sorry to interrupt. I forgot the order there. I just wanted to add to the point of a visit sort of merging after the fact into a billable service, that I would argue that's not in compliance with this statute, because consent needs to be obtained ahead of time. So it can't be, I just want to emphasize again, this can't be a surprise to the patient if it is the provider's not
Surprise
following
billing.
the law.
All right, Sarah, we're
So-
going to get to you, Senator. Don't worry.
It's okay.
So if you look in the language, it allows one-time consent for all audio.
Oh,
So a
okay.
patient can give consent once and then be billed
Oh.
anytime thereafter. That there's no.
oh. Okay, so
I think I would disagree with that. The way the
Oh.
language is written does not require for an ongoing relationship by audio only. The consent does not have to be obtained each time. But if they're sporadic, it's not part of a regular sort of regularly established ongoing, like the one that comes to my mind is working with a mental health provider where it might be a weekly telephone visit. That doesn't require informed consent each time, but otherwise there is informed consent required. So that's the only, as I read it, that's the only time that they don't have to provide it each time. The provider
Okay, but
doesn't have to-
let's flag that one just a little bit, and then we can do some thinking on it. Senator Hooker.
Thank you. And I think that things are beginning to be clarified to a certain extent. But I guess my question is, what is a visit? Is it when I call and make an appointment? What's the difference between a visit and an appointment? When I think of in-office visits, I think of I've called the doctor's office and said, I'd like to see the doctor. And I make an appointment. So when I call the office, can the doctor say, can we do this over the phone? And then I can agree to it or not. But I guess I'm just really confused as to what the difference is between an appointment and a visit.
Can I answer that question?
I hope so.
As a patient, I'll give you a patient response and then I'll let Jessa or Devin or Sarah chime in. So as a patient, I have been recently treated for some tick-borne illnesses. And my first call, which was a long time ago, it's still ongoing. First call was a triage call. And I talked with a nurse and the nurse said, oh, I'll get back to you. Someone in the office will get back to you whether you need an appointment. So that I never charged for that. Never saw it on a bill anywhere. Then went into the office and had an appointment. More recently, I've been allowed to have video conference and audio only. I actually even had 2 audio only appointments. And I had to provide consent for those. I did provide consent for those before I did them. The practitioners are extremely sensitive to some of this. So, and I was charged for the audio only. Okay, certainly this is under the pandemic, but it was a long, almost an hour long audio. So these things are happening now, but I'll let Jessa answer and Devin. Any comments there from?
I agree. I think it can work both ways. I'm sorry, for the record, Jessa Barnard, Vermont Medical Society. I think actually one of the benefits is that this gives us, as I know it's kind of becoming cliched, but more tools in the toolbox and more flexibility to meet patient requests and patient preference. So it could be that the patient initiates the call to the office, to the nurse. I think just in my patient experience, it's rare that you pick up the phone and call and immediately get the clinician on the phone. But it could be you call in the middle of the night, get the on-call doctor, and it could be that the doctor says, well, I think we can deal with this tonight over the phone. Do you want to have the visit? I don't think you need to go to the ER. Let's actually have a visit. Send me some pictures. Let's talk about this. That could, the patient initiated the call. That could actually turn into a real, a visit. I think the more common scenario is, you call the nurse or the receptionist, you get an appointment scheduled, and maybe that appointment is over the phone, and you say, yes, I'd like to do it over the phone. It's pre-scheduled, it's ahead of time, it's going to happen. I think that's probably the most common way this would ever be used and is being used right now. There could be some instances where the patient sort of initiated a call and it turns into a full visit, but I think that's much rarer. I don't know if Devin has any other.
No, I agree. I think like we were saying, that 7 a.m. hour at the pediatrician's office, that's the time for the triage calls. And then if, it sounds like there's something more that needs to be done, that's when the nurse can say, you can come into the office or you can have an audio, this is appropriate for audio only. And maybe you're sitting around on Zoom all day and you can't really leave for the whole 2 hours it takes to get into the office and you prefer audio only. So that's where it would come into play.
And we don't get paid for the 2-hour wait. Right, sorry. Okay, I'm sorry. I had to say it. Any other questions? Jen, why don't we put the language back up and look at the 2 paragraphs we've been reviewing and then move on, unless there are other questions.
Okay, and can I just check, Senator Hooker, has your question, do you feel like your question has been answered?
Yeah. I'm still wondering kind of about that 2:00 in the morning call. Am I going to get charged for that? Where, my pediatrician said, and it's dark, so, is that something that I hear you say it could evolve into an appointment or a visit and be charged, but the patient would have to have notice before that happens. Okay.
So that's something to keep in your mind as we go through the language. certainly. Yeah. Senator Hardy, were you about to
Sure.
say something?
No, I'm
Okay.
fine. Thanks.
Okay, so here we were looking at the coverage requirement and then the reimbursement parity requirement. So again, coverage for all medically necessary, clinically appropriate services delivered by telephone to the same extent they would be covered if provided in person. And then it requires the plan to provide the same reimbursement rates for services that are billed using equivalent procedures, procedure codes and modifiers, regardless of whether it was provided in person or by audio only telephone. Then we have the exception if the insurer and provider have entered into a value-based contract. It allows a health insurance plan to charge an otherwise permissible deductible, copay, or coinsurance for healthcare service delivered by audio only telephone, as long as it does not exceed the amount that would be applicable for an in-person consultation. And then here's the last piece. This is the other part that Senator Cummings was focusing on. Health insurance plan shall not require a healthcare provider to have an existing relationship with a patient in order to be reimbursed for healthcare services delivered by audio only telephone. I don't know if you want to stop
So
here.
let me ask a question about this one, and so maybe the providers and the insurers can help me with this. But there are cases where, and I already see the answer, but I'll ask it anyway. There are cases where consultation is put in place. So with some kind of orthopedic or rheumatological condition or whatever it is, or whether or not somebody should have their tonsils out, you go for a consult. So suppose the consult is done for audio only because all the pictures are available. Is that how is that charged? Would that be charged? Who wants to help me? Nobody. Okay.
I'm happy to weigh in if you would like.
Yes, I will.
Jessa Barnard with the Medical Society. Yes, I think this language would allow for that. Again, if it's clinically appropriate, only if the provider has all the information needed in front of him or her, access to the medical record or records sent over. But I actually think consults could be a good example of where, if that specialty feels like enough information can be gathered that way. I think you heard from a number of the clinicians that in most cases, they prefer a first visit in person, if not audio visual. So I think it would be rare, but I think there could be examples of a specialist giving a consultation. They have all the records in front of them, and they can then have an hour or half-hour long phone call with that patient to talk through what their opinion is. I think that is an appropriate example.
Okay, and I immediately jumped to knowing that we also have store and forward.
Correct.
Okay.
So that would be asynchronous, but if it was but then they want to sit down and have the synchronous, phone call and talk through this, answer questions, give their opinion. I think that would be allowed to be a billable service under this structure.
Okay. Okay, other questions about this then? Senator Cummings, you have questions about that paragraph, I know.
I think what I'm feeling a lack of is knowing what would give the health insurance providers surety. They've told us their concerns, but what kind of alterations would give them some feeling that they had some control over rates? Because this is a brave new world. We like to think that all healthcare providers are wonderful healers, but I believe the head of the medical practice board did tell us that some people see this as a money-making proposition. And I'm trying to find a way to enter this brave new world, knowing that it may just turn out, and quite probably, because I doubt that Medicare and Medicaid are going to continue after the pandemic. with parity. So we've got a very small group, many of them quite vulnerable to the cost of healthcare. I'm trying to find a middle road here that gives us some surety that we're not going to do damage with rates. And I haven't heard what would make the insurers happy. I've heard that the providers really love the idea that they're being paid for something they haven't been paid for, and that there is clinical value in this. But I haven't heard specifically from the other side if they have proposals that we might look at.
Okay, now I have Sarah, Devin, and Chuck. So we'll go actually sort of in that order. So let's do that. Go ahead, Sarah.
Okay, so requiring in statute that we pay parity for all services for the next 5 years is really the focus of our disagreement. We agree that these are important services and some of them should be paid for perhaps at parity, but perhaps not. And we would like to negotiate the appropriate amount of payment for whatever the service is.
Okay, I may comment on that afterwards. So, but I want to hear from Devin and Chuck.
Thank you. Devin Green from the Vermont Association of Hospitals and Health Systems. I don't think I introduced myself before. Sorry about that. I think the guardrails are already in the legislation. This is providing access to care that we did not have before. And it gives the providers and the patients the tools to make their own decision about the appropriateness. By being reimbursed at parity, and the subsequent copay that comes to that, and the notification about the possibility of a copay, the patient can decide, am I willing to spend the money for this service, or do I feel like I need to go in for this service, or do I want to forego care? And we all see what happens when people forego care. A lot of times that drives up costs in the system. There's a RAND study that just came out that showed that the people who benefited the most from this were vulnerable populations, and that if audio only was taken away, those population, the study aligned around FQHCs, and FQHCs would likely not be able to offer audio only, and so those populations would not receive that care any longer.
Devin, who are the vulnerable populations?
I would say folks in rural areas, elderly people, low-income people who might not have transportation.
Okay, but those are the ones we aren't controlling.
People in rural areas, I would also say they're not vulnerable, but I think there are other patients who want this tool too. I mean, as a working mom, I want this tool available to me as well.
Chuck, did you want to add?
Yes, thank you, Madam Chair. Chuck Storrow for MVP. Basically what Sarah said, which would be to require coverage for audio-only healthcare services, but do not specify the reimbursement rate. And in that way, we can all feel our way along going forward. It doesn't deprive providers from having that ability to provide audio only. And if it turns out that the payers and the providers are not able to come to agreements on reimbursement that facilitate the providers being willing to provide audio only services, then the issue can be looked at and adjustments can be made by the General Assembly. But that in the meantime, let us try and feel our way along.
Okay. Jessa, and then we'll go to Senator Hardy because she's now waiting to ask a question.
Thank you. I have a couple comments on the eliminating the parity piece, if I might. I think the real concern about eliminating parity is that's going to lead to inequitable access to services, because Vermont law requires parity for audiovisual telehealth services. That's already in statute. It passed, was that 2 years ago? So it's going to target just those people who lack broadband and lack that access. And unfortunately, I think providers, we have another issue we'd love to talk more about the committee about, closing small private practices. I think just the truth is that if they're not reimbursed fairly, practices will not continue to offer this service. And not to mention that it's a service that patients would have to want this service. So it's something patients would be requesting, and it would be having to provide the same level of care. It's the same code. And we know that small practices really don't have leverage in the negotiation with insurance companies. I just want to put that out there, that there's a community rate that is paid to all practices, and that it would be a take it or leave it situation. And I don't think that would lead to fair reimbursement for the smallest, most vulnerable providers in our state.
Okay, thank you. Senator Hardy.
Yeah, I'm struggling with this one because if it were more black and white in terms of the patients that we really, really want to target, which are elderly patients and patients who are lower income, it would be a much easier call for me to say, yes, we want to do this because we want to make sure those patients have access, but they're not even on the table with this conversation because of the payers that pay for their services, Medicare and probably Medicaid. And then the large group self-insured are also not on the table. And I hear you, Devin, about wanting to have this convenient option for working parents. I'm completely with you. I've used this option over the last year several times. And in fact, requested it many times saying, this is not convenient and we're in a pandemic. Can we just do this? Actually, I didn't use audio only. I used telehealth, actually, the audio visual. But I am wondering, we talk about patient access and affordability, and I'm still struggling with the whole concept of parity, because it seems to me that providing these services via phone is actually going to be cheaper for providers, because you don't have to have somebody come into your office and use your medical supplies, use your staff time as heavily, use your facility, and you can do it by phone. And, literally, and we've heard from some people that the patient is taking their blood pressure. The patient is doing a lot of the stuff that a provider would have been doing or a nurse would have been doing. And so it seems to me that in some ways this should be cheaper for the patient, and that would actually provide better access. If the patient says, oh, I could either go into the office and be charged $50, or I could be at home and do it by phone and be charged $30, or be at home and do it by telemed audio visual and be charged $40. They might say, oh, I want to do the 30, and they're all clinically equivalent. They might say, I want to do the $30 call because it's going to be the same care and it's going to be cheaper for me. Or maybe they want to see their doctor in person or in face-to-face, and they'll say the $40 call is what I want. Or maybe they really want to go in and they'll take the $50. I don't know. It seems to me that there are some savings to providers in this. And while I hear you, the arguments about the small independent providers and not getting, I'm just really struggling with this different cost differential and the fact that we're not really talking about all patients in Vermont. We're leaving out a huge chunk of patients in Vermont.
My turn. So thank you, Senator Hardy. So I'm thinking about our definition of vulnerable patients, and it's one thing to define them as only people who are lower income and only have Medicaid, but it's another thing to define them as those with cancer recovery or rheumatological conditions under which they can't leave the house, or they can't get up in the morning because they hurt so much, and they need to have an appointment by telephone. So I'm not willing to categorize vulnerable patients in the way that they have been characterized, because I know too many who do not fit into that narrow definition. So that's one. And we do know that not everyone is going to be covered with this. But here's what we also do know. the codes are there. It won't be any different treatment from what is currently being given. There will be justification and record keeping. That's key. We haven't gotten there yet, but we've heard it's there. We know it's there. And then the other piece for me is all the questions we're asking are the right questions. This is the information we want to know. But there's no way we're going to know if we start the process from on one side saying, well, the insurance companies have all the data. Well, if they have all the data, that would have come out during the DFR reporting process. And do all the providers have the data? No, they don't, which is why we need to have guardrails in place so we don't get what Senator Hardy is talking about, which is a practice that is totally audio. That's not the intent. So that's a good point raised.
That's not what I was talking about, Senator
No,
Lyon.
I know that.
I'm saying that if we provide patients with the options, they might choose the lesser cost option because the practice doesn't have as many costs of providing audio only. And I haven't heard testimony that says that there's parity in cost for the provider.
We don't know. We don't
and
know.
I'm all for getting the data. I'm absolutely absolutely in favor of getting data. I'm not sure we need the large window that we have in this bill.
Okay, well, we're going to get to
much longer.
Good point, but we haven't gotten to the time issue. We've heard that 2025 is like an eternity, so we need to get to that. Good point, Senator Cummings.
Yeah, I guess I'm not clear. I think we all know we need data. This is a brave old world, but getting paid is new.
World. Good.
But why? I'm not sure why paying a different rate rather than full parity would keep us from collecting data. It might collect more. I'm thinking of Margaret Lagus, who has a high deductible, and she can go online and pay $50, or she can go to her doctor and pay $125. And we have a lot of people in Vermont with high deductible insurance. So that's the other part of the brave new world that's out there.
And I guess my question would be then, how would you know what rate to set for each of the codes that are in place? And I think that's the kind of information we're trying to get to. And you really struck a chord. How do we know? And will patients choose because it's costly? We just don't know. We don't know what we don't know. Jessa Barnard.
Thank you so much, Jessa with the Vermont Medical Society. I would love to respond to Senator Hardy's point about the cost of providing care. I think it's a great point. I would respond that we have actually heard loud and clear from our members that in the near term, we cannot capture those savings. And it's exactly to your point of why there's a time limit on this and why we want to move to value-based payment, because in the long term, that could be true. We could see mental health providers working only from their home and not renting an office space anymore. Or we could, maybe staffing of an office would look different. Maybe there's an entire telehealth team versus the in-person team. But that's all going to take time to put those changes in place. And right now, actually, there was testimony maybe it was in the House Healthcare Committee from several clinicians about, they have long-term rentals on their properties. They have their staff they've hired. They still need that staff to triage the phone calls, to talk to the patient ahead of time, gather the records, make sure they're getting the blood work done ahead of time, call to make sure they've gotten the consent and walked through what a telehealth visit's going to look like. Actually, maybe even prep them to get Zoom on their computer and how to do, and Kathy, I see her hand up. I'm sure she can talk more about that whole process involved right now on getting patients. Zoom, I guess, is in the wrong context. That's not the phone, but getting them, here's how I'm going to call you. Here's when I'm going to call you for the phone. So we have definitely heard from our members, at least, that costs are not lower yet. But maybe we will get there, and maybe a value-based payment would take that into account in a couple of years from now.
Kathy, do you want to comment? And then I think we should move on to the next paragraph.
I'll
gonna
just
take
comment
us a
very
week.
quickly to echo what Jessa said, that in the short term, the fixed costs are probably the same. They're a wash. And from a quality perspective, the importance of integrating new workflows and getting it right and supporting the learning, curve for blended systems is just really important to make sure that's supported as well.
Okay, thank you. Jen,
Yes.
this is good. This is putting everything out there and it's very helpful, I think.
Okay, so the language that we had looked at most recently was around the existing relationship. I don't know if there's more you want to do on that, whether there has to be an existing relationship or move on.
I guess, let me ask committee on a show of sort of the draft support for not requiring an existing relationship. How many of you, I can't see you all, but I can scroll through. Just put your
I can
hand
take
up.
it down.
Okay, yeah, no, I'm just curious as to
right.
whether or not you'd like to change that.
I have a problem with blankets.
Okay,
I
wait,
think
okay,
because we'd be getting mental health in there.
Yeah.
And I think there's a difference between a mental health crisis call and just calling up a general family practitioner that I've never met. And telling him a child he's never met.
okay, so
As
what I'm hearing you say is that is problematic. The blanket statement's problematic. Does anyone else feel that way? Shake your head, yes or no. Okay, so let's come back to that. And then Senator, you've brought up a very good point about how to define the relationship. And we've also heard from folks that we shouldn't be separating out mental health from other healthcare and environments, but because we work very hard to have parity within those two, but we'll have to sort that out. All right.
Well, can I just add, I mean, I think there could also be an exception for, I don't know what the correct term is, but cases of urgency or emergency. If, there's a case where somebody is new to Vermont and doesn't have a provider and needs to see a doctor right away for something. I'm not sure what language, but I think that we're not singling, and I think we're not singling out mental health. We're actually saying that we want to provide this service for mental health.
No, I agree with that, but some folks have suggested that by doing that, we're singling them out. So I want to be clear with that. I didn't say that, but
don't give them first.
that's what I've heard in some of the testimony from people. Okay,
I haven't.
Jen.
Right, so that first piece was all on the insurance coverage. That was section 1. Section 2 looks at it more from the provider, what's required of the providers. And so this would be in a renamed chapter and subchapter using the broader term telehealth, because our telemedicine definition is audiovisual. So this would be a new section, healthcare providers delivering healthcare services by audio only telephone. We piggyback on the same definitions as in the insurance statutes for health insurance plan and healthcare provider, and the definition of telemedicine from the telemedicine insurance statute. Then we say, subject to the limitations of the individual's license and for Medicaid patients to the extent permitted by CMS, a healthcare provider may deliver healthcare services to a patient using audio-only telephone if the patient elects to receive the services in this manner and it is clinically appropriate to do so. It would require a healthcare provider to comply with any training requirements imposed by their licensing board on the appropriate use of audio-only telephone and healthcare delivery. I'm going to keep going. Keep going. A healthcare provider delivering services using audio-only telephone must include or document in the patient's medical record. So this is some of the language we were talking about earlier on what's in the medical record. The patient's informed consent for receiving services using audio-only telephone in accordance with the provisions that are set out in subsection C, and the reason or reasons that the provider determined that it was clinically appropriate to deliver healthcare services to the patient by audio-only telephone. It specifies that a healthcare provider shall not require a patient to receive healthcare services by audio-only telephone if the patient does not wish to receive services in this manner. And a healthcare provider must deliver care that is timely and complies with contractual requirements and shall not delay care unnecessarily if a patient elects to receive services through an in-person visit or telemedicine instead of by audio-only telephone.
I don't want to interrupt too much, but I just, is there anywhere in here the conditions established within the informed consent form?
We're about to get into informed consent.
Oh, right.
Yes,
I was
that's the
hoping.
subsection
I knew it was
C.
there somewhere. Okay.
Subsection C requires a healthcare provider delivering healthcare services by audio-only telephone to obtain and document a patient's oral or written informed consent for the use of audio-only telephone prior to the appointment or at the start of the appointment, but prior to delivering any billable service. The informed consent must be provided in accordance with Vermont and national policies and guidelines on the appropriate use of telephone services within the provider's profession, and must include in language that patients can easily understand that first, that the patient is entitled to choose to receive services by audio-only telephone, in person, or through telemedicine to the extent clinically appropriate, that receiving services by audio-only telephone does not preclude the patient from receiving services in person or through telemedicine at a later date, an explanation of the opportunities and limitations of delivering and receiving healthcare services using audio-only telephone, informing the patient of the presence of any other individual who will be participating in or listening to the patient's consultation with the provider, and obtaining the patient's permission for the participation or observation, and whether the services will be billed to the patient's health insurance plan if delivered by audio-only telephone, and what this may mean for the patient's financial responsibility for co-payments, co-insurance, and deductibles. Then we get to the if for services delivered by audio-only telephone on an ongoing basis, so this is what I was talking about earlier, the healthcare provider shall be required to obtain consent only at the first episode of care. If the patient provides oral informed consent, the provider shall offer to provide the patient with a written copy of the informed consent. Jessa mentioned this earlier. Notwithstanding any provision of this subsection to the contrary, a healthcare provider is not required to get the patient's informed consent for the use of audio-only telephone services in the case of a medical emergency. A healthcare provider may use a single informed consent form to address all telehealth modalities, including telemedicine, store and forward, and audio-only telephone, as long as the form complies with the provisions of the telemedicine and store and forward section 9361 and this section. That's the end of the informed consent. There's a couple of other pieces. I can keep going, or I can stop if you want to talk about it.
Let's just see if there are any questions regarding the informed consent section. Okay, let's keep going then.
Then we get to, this was brought up earlier, neither a healthcare provider nor a patient shall
Your little
create.
screen got little. Can you make, what
My
happened
little
to
screen
that
got
screen?
little.
How come it got
I didn't-
smaller?
I don't know what, nothing changed on my end. I can take it down
Yeah,
and put
no,
it
it
back
did
up.
change
That's
on our
all.
end, but there's, go ahead. Don't worry about it.
Okay. Can people see the language?
Yep. It's just smaller, that's all. It's not 40 size font.
No, it is not 40. All right, so neither a healthcare provider nor a patient shall create or cause to be created a recording of a provider's telephone consultation with a patient. And finally, audio-only telephone services shall not be used in the following circumstances. And these are circumstances for which telemedicine, the audio-visual, can be used. So cannot be used for the second certification of an emergency examination determining whether someone is a person in need of treatment. This is for mental health purposes, or for a psychiatrist's examination to determine whether an individual is in need of inpatient hospitalization. So again, that's in the mental health context. Do you want me to stop here? Or
Let's stop here for
keep
a
going?
minute. Are there any questions?
I'm going to take it down so we can put it back
Yep.
up. See if we can-
Okay, any questions on that section? The not section? Okay. I guess we'll just keep going, Jen.
Okay.
Hmm?
We back to full size?
Not yet. It's okay.
Okay. I don't know what you're seeing.
I
Okay.
don't know what other, is anybody else has it gotten smaller? No, just
No.
my screen. Okay.
You can adjust it on your screen to make it smaller or larger. I always keep mine small and look at it on my other screen so I can see people. So I don't know if that's what's happening.
We'll find out. Go ahead.
All right. Section 3, this is where we get to the data collection. This would require by July 1st of this year, the Department of Financial Regulation, DFR, in consultation with DEVA, the Green Mountain Care Board, representatives of healthcare providers, health insurers, and other interested stakeholders, must determine the appropriate codes or modifiers or both to be used by providers and insurers, including Vermont Medicaid to the extent permitted by CMS, in the billing of and payment for healthcare services delivered using audio-only telephone in order to allow for consistent data collection by insurers, to maintain reimbursement rates equal to those for in-person services, to identify appropriate codes for services that do not have in-person equivalents, and minimize the administrative burden on providers. To the extent possible, the use of codes or modifiers or both would be done in a manner that allows data on the use of audio-only telephone services to be identified using VCures, the All-Payer Claims Database. So that was by July 1st. Then not later than January 1st of 2022. So for the starting by the new plan year, if not before, all Vermont licensed healthcare providers and health insurers offering health insurance plans in Vermont shall use the codes and modifiers determined by DFR under subdivision 1 when delivering services by audio-only telephone. Vermont Medicaid must participate to the extent permitted by CMS. So that then is starting our data collection no later than January 1st of 2022 with everybody using the same codes and modifiers. So that then after plan year 22 and after all of the claims data has come in going into 2023, by the end of 2023, by December 1st of 2023, leading into your 2024 legislative session, the Department of Financial Regulation, VPQHC, and to the extent VCures data are available, the Green Mountain Care Board must present information to the House Committee and to this committee regarding the use of audio-only telephone services in Vermont during calendar year 2022. So looking at the 2022 calendar and plan year to determine the use of audio-only telephone services during that time. The department must consult with interested stakeholders in order to include in its presentation information on utilization of audio-only telephone services, quality of care, patient satisfaction with receiving healthcare services by audio-only telephone, and the advantages and disadvantages of the provider parity of reimbursing providers the same amounts for services delivered in person and by audio-only telephone. I see a hand.
Senator Cummings has a question.
Yeah, Could we add impact on rates in there?
Which you certainly could. That was sort of where I was getting at, or at least some of it with the advantages and disadvantages of the provider parity. Some of that might be,
Why don't we
Either
say,
I thought that, but
we can be, sure.
the impact on rates to me.
Yep.
'Cause we're getting down to a very small subset here.
well, it'd be interesting to see what happens, and in particular with Medicare and Medicaid. I guess a question I also have around that is, and I guess only the payers will know the answer, which is there may well be some extension of audio only through the ESI. And
What?
through ESI, through
PSI,
self-insured folks.
Oh, that's a little different. ESI is employer-sponsored
I know,
insurance.
employer
It's broader
sponsored,
than.
I know.
Okay,
okay.
or
but the
self-insured.
self-funded you're talking. Okay.
Self-funded, yep. So, and if audio only does happen with, through those folks, is there any way at all to ask and get the data from them to expand the universe?
Well, to the extent that they voluntarily report data to VCures, you may get some information from there. You may also be able to get information from their third-party administrators. So for example, for a Blue Cross or Cigna administered self-funded plan, they may be able to provide you some information on utilization, but they would be better ones to tell you that.
Can we politely ask for that? Sarah or Chuck?
So this is Sarah. We ask all of our self-funded employers to, whether or not they will have their data as part of VCures. And the two largest do, State of Vermont and VHI.
Okay, so
And
we
you
might-
could get, you can require State of Vermont and VHI to report their
yeah, we could require it.
information because they're governmental.
But
So Senator Cummings, go ahead, and then Devin Green.
okay, but State of Vermont and VHI would not be required to do.
Yeah.
To pay this reimbursement rate.
State of Vermont would because of actually, I think they both would based on the definition of health insurer that we've used that includes self-funded plans to the extent permitted under federal law. And because it's a governmental plan, it is permitted under federal law. And it's my understanding.
State just go to the value.
They've gone
No.
to value-based payment. They
Yeah,
will,
didn't they go to the, and
yes.
is VHI joined that too?
I don't think
So
so.
are you talking about participation in the ACO?
Yeah,
Is that what you're talking about? The state employees, I believe, have or are in the process of joining. So to the extent they're doing value-based contracts, then they would fall, I think.
they
under
are
that.
not, they're not included in
Section.
this.
But I think we're getting into more level of detail on this than I'm prepared to
I'm just
answer.
trying to,
Maybe
figure- we,
others on
we
the call.
keep shrinking who's going to be impacted. I
Well,
think
the
is-
question I think would be, can we collect audio utilization from these groups? And it may demonstrate that there is some relationship between cost and value-based versus fee-for-service. So that's why I was asking, can we collect that data? That's all. Okay.
You should be able, and there's no, the federal preemption issues around ERISA do not apply in the context of governmental plans. So you can require self-funded governmental plans to do things like report their claims information to VCures and also to provide whatever benefits you want them to provide. If they are participating in the ACO, there may be, I would expect there would be separate data collection happening through those processes as well that may inform some of your decision-making.
Okay, thank you. We can put that in. We could ask, we want that information.
And I think Devin may have something to add if you're interested.
Yes, I want to hear Devin. Go ahead.
Actually, I just wanted to expand the universe of people a little bit more. I know we keep discounting Medicaid and saying that they're not included, but the language we have in there now is to the extent that the feds allow, which is basically just to make sure we cover our bases. And Medicaid, there's nothing that disallows Medicaid from covering this now. And in fact, New York and New Hampshire are both covering audio only through Medicaid.
Right. Thank you for that reminder. Okay. Any other comments, questions? Senator Hardy?
Thank you. I'm just wondering about the timeline. Did we just talk about this? I'm sorry, I just got distracted by a family issue. But did we just talk about the timeline or?
Well, that was in the language.
Okay.
I can put the language back up and we can look at that again.
Yeah, let's go back and look at the timeline because it's part of the timeline. So let's look at what we have here right now and explain it to us, Jen. That'd be helpful.
Sure. So by July 1st, we have DFR and others figuring out what the codes are for everybody to use so that the data collection can be consistent, to have the same, to have the reimbursement rate parity, and to minimize the administrative burden on providers by having a single set, to the extent possible, of codes to use. So that's all by July 1st. These codes are identified. And then by January 1st, so for the 2022 plan year, if not before, so not later than January 1st, all Vermont licensed healthcare providers and health insurers would be using these consistent codes and modifiers. And Vermont Medicaid participates to the extent allowed under by the feds. So this data is being collected for healthcare services delivered during 2022, from the beginning to the end of 2022, and that the claims tail takes us into 2023 before some of this information will be finalized. So this information is collected through 2022, and these codes continue to be used into 2023, but it's really to have a full 2022 data set to use, so that by the end of the year, on or before December 1st, leading into your 2024 legislative session, DFR, VPQHC, and the Green Mountain Care Board would present information to these committees regarding the use of audio-only telephone services in Vermont during calendar year 2022, which is also plan year 2022. And they would consult with interested stakeholders so that the information would include utilization, quality, patient satisfaction, pros and cons of reimbursement parity, and I can add in specifically the impact on rates. So that is that piece. And then, and just to jump ahead for a moment, the audio-only reimbursement parity would be repealed on January 1st, 2025. So
Well, but that would be unless some other requirements were put in place legislatively in 2024.
That's exactly right. So that's why this information would be coming to you leading into the 2024 session to allow you to make decisions, or you or whoever is sitting in your seats at that time. The reimbursement parity would expire just starting in 2025. So at the end of 2024, unless the legislature does something during that 2024 session to change that, whether it's extend or modify or else allow the sunset to occur.
Okay. Senator Cummings.
Okay. I understand that we're trying to collect data, and I understand the timeline, but are we right now not able to get data from Medicare? Is that out of the question altogether?
I mean, you do collect data. Certainly they're required to report to, or they agreed to report to VCures, but I don't know what the way the coding works, whether that information is available or not, so I know some of the carriers have not been able to differentiate based on the codes that were used, whether services were delivered in person, by telemedicine, or by telephone. I don't know what the case is for Medicare, and I'll put this down in case there are others who have information on that.
Okay, but if Medicaid, which right now is tied to the national public health emergency, if that emergency ends in October 2021 or January 1st, 2022, and Medicaid goes back to where it was, it's not paying, at least, then we lose that data set, right? Because they're not paying for it's the, and I'm wondering why don't we tie it all, the end date, to when we start to, when we lose the two big populations we're used to, or we're concerned about.
Well, I don't think we have clarity about what CMS will do for Medicare and Medicaid when the national public health emergency is over, as far as whether to tie the commercial side to what happens with the public side, I think is a policy question that you may want to hear from stakeholders about.
I saw one stakeholder hand open up. I don't like the word stakeholder, but we'll use it anyway. The interested parties. Devin, I saw your hand up, and then Helen, I thought I saw your hand up. So Devin, go ahead.
Sure. I guess I would just reiterate again, I think there's a vast difference between Medicare and Medicaid. I think Medicare is much more tied to the end of the pandemic because that was a specific, emergency measure that was taken. With Medicaid, that decision, we have not seen the feds disallow it. And that was a decision that states made, and that decision has been left up to the states. That could change in the future, but I would say that that is less tied to the pandemic than something like Medicare. And I will let Helen correct me if I'm wrong on that.
Okay, but Diva testified that if we required them to do this, they could end up out of compliance with federal law, and they did not want to be there. So they seemed to think that there was a possibility.
There's a possibility that the feds could say no with their waiver or something to that extent. I think they just didn't want to see that disconnect between state law and federal requirements. That was the sort of covering their bases language that they were putting in there.
And I would just add that we put that in a fair amount for Medicaid, always recognizing that what Medicaid is allowed to do will depend on what the feds say Medicaid can do.
And that was my understanding when I talked with Diva about this, that it was really a protection to ensure that we were following federal law. Helen, did you want to add? And then Sarah.
Yeah, just to clarify on the Medicaid side, so nationally, there is a lawyerly dispute over the definition used for telecommunications systems within CMS and who has regulatory authority over it. The hope is that Congress will simply pass statute that clarifies it all. And that's one of the major holdups why we keep saying we can't be sure what will be allowed for reimbursement. And this isn't a question of what's allowed for, like, you're allowed to practice medicine. There are telephone codes. It's a question of what the federal payers will match for reimbursement is the issue here. And there are many legal minds working on it right now who has authority to change that.
Can I ask a question? So you said that there's a dispute over the authority, and it is between which entity and which entity? So I'm thinking CMS and FTC, FCC, or what?
CMS and Congress. So under the previous administrator, CMS had interpreted the statutes to mean that Congress needed to act, and others disagreed with that interpretation. So that's being discussed right now. we probably won't solve it here.
I don't think Congress will solve it either, but so be it. Sarah, you had a comment.
Yeah. My comment is that the data will be collected regardless of whether or not we pay at parity. And so the date, the 2025, which is 5 years out, doesn't matter as much if we're not paying potentially excessive amounts for some of these audio visual visits, audio only visits, excuse me.
So if we actually look at the dates, conceivably, it could be 3 years. I mean, so if the folks come back in 2024, the data is there for the 2022 calendar year, then and the legislature acts with alacrity, which we're very capable of doing sometimes, we could see a light at the end of this little tunnel. So I mean, 2025 sounds like a long time away when we say it's 4 years away, but when we think of what the reality is, that the emergency hasn't ended yet, and then that we're collecting 2022, it's going to go on for a whole year, and nobody wants to see this conversation, protracted conversation. So we could be optimistic. Senator Hardy.
Yeah, I was wondering if we could crunch the timeline a little bit, but I first have a couple questions related to that. So if we require DFR to come up with new codes by what is it, July 1st of 2022, right? Is that, Jen, the
Up with
first?
the codes?
Yeah.
Is July 1st, 2021 this year.
2021, right. So by July 1st of this year, those new codes would then not have to go into effect until January 1st. Could we make them go into effect sooner?
Everybody would have to start using them not later than January 1st so that you can get a full year of data collection. So people could start using them before then, but the idea was to see how consumers behaved over the course of a whole plan year, because people might behave differently with respect to receiving healthcare services in November or December when if they've met their deductible, or they have or have not had certain numbers of or preventive visits or other types of things than they might earlier in another plan year.
I see. I mean, could we do it like October 1st to October 1st? And that would still capture the end and the beginning of a plan year, but it would just, I'm just trying to figure out if there's a way to crunch the timelines. We have the data, we can do this. It just seems very protracted. And I don't know.
You might have different people on the plans. People change plans, change carriers from one plan year to the next. I think that.
I don't know if that matters. But. Yeah, I mean, I hear you. You're obviously, we all get, well, not everybody, but there are options to change plans at the end of the year. But I'm just wondering if that even matters. We're trying to get this sort of like bigger picture of the use of tele-only, audio-only. Doesn't matter who it is necessarily. We've already crunched the universe down to only some people. And then my other question is, if we come up with these codes, or DFR comes up with these codes by July 1st, does Medicare have to use them?
No.
Okay. So I'm trying to figure out and we just sort of talked about this, but how do we capture the data on Medicare use? I mean, at all, can we even get that data, even though they're outside of this bucket?
So I'm going to turn to Helen, if I may, because I think she knows the most about who uses what codes. And Helen, I don't know if it sounds like there may be distinct audio only telephone codes in Medicare that would still provide that information.
Yeah, so there are a couple of levels in here. So Medicare is the biggest mess you've ever seen with coding for telehealth right now, to be perfectly frank. So don't expect anything useful. That sounds very glib, but it's really, I mean, they keep changing the codes. So they haven't even sorted out 2020 codes yet. We're still having our claims reprocessed. So it's just not a viable source of information on any time frame that we are looking for. I hate to say it, it simply isn't. And we do not code in a way, at least for the FQHC side, we have a fully bundled code. So all you would know was that there was an encounter at an FQHC and it was not in person. That's all that you would know from the office visit codes,
Okay.
unfortunately.
That's really unfortunate because from everything we've heard, the people who generically benefit the most are seniors, and we're not even going to have that data from audio only, the ability to use audio only. So I still come back to that. So if it's possible to crunch the timeline so that we are making these decisions faster, I think that would be helpful.
I believe that one bright point on the Medicare that I think might help with the overall theme here is that they do have very detailed coding for the virtual visits that are not an in-office visit. So the short calls, the chronic care management, the remote patient monitoring, that is much more robust than at the state level. So you will have that possibility of getting data. I think that sort of speaks to a larger timeline point that might help alleviate some of your concerns. One of the, we're talking about this in terms of just knowing what the impact of turning on audio only at parity is. But the real goal here that I think is shared by both the providers and the payers is to get to an alternative payment model that's value-based and that encapsulates both the office visits and all these different types of codes that aren't office visit equivalent and does it much more elegantly. So that's really the big goal in this data collection. And there is in the proposed language an off-ramp there. As soon as we can get to a point where we have this alternative payment model, we can enter into that contract. So it's not like if we come up with a great solution before January 1st, we're trapped into waiting. If we can make the data work sooner, then we have that option to coming into a new payment model.
It just seems like we're waiting for the report till December 1st, 2023 for the previous plan year. That's almost a year after the plan year ends. And I know obviously you can always come in early, but very few people turn their homework in early. And so can we make it crunch the timeline, and does it have to be on a plan year to plan year?
Well, you need sufficient data. You need at least a year of information. So a half a year probably is insufficient, and a whole calendar year allows for the whole cycle of insurance plans as well. So Jen, let's go through again exactly what the timeline is, and then we'll think carefully about whether or not there's any way to shorten that. So on or before, this is July coming up. So we have
Right.
July, go ahead.
On or before July 1st of this year, DFR and others must determine the appropriate codes or modifiers to be used by providers and insurers. So July 1st, identification of codes and modifiers. By January 1st, everyone starts using these, everyone who we can require to start using these, starts using these codes and modifiers. Then on or before December 1st of 2023, DFR, VPQHC, and the Green Mountain Care Board provide information about the use of audio-only telephone services in calendar year 2022.
Let's just stop there for a minute. So the collection of data goes from January 1st, 2022 until?
Well, the data collection, I mean, they can continue longer than 2022, but you have asked for, or you would be asking for information on the use of audio-only telephone during calendar year 2022.
Okay.
And then that's basically it, other than the reimbursement parity piece ends after 2024. So it's literally January 1st, 2025, but it's really It's at midnight, so it's the end of 2024.
Senator Cummings.
Okay, being a veteran of trying to change rates, several times there's been proposals to change rates. The rate setting and approval operates on its own time frame. I believe it starts and has to, by the time we get back in session, it's pretty far down the road and it's difficult to make changes. So while we're collecting data, and I'm still not sure why we need to have full parity in this limited set while we collect the data, any increased cost is going to be reflected in the rates. And I'm trying to figure out, would it be if we're already seeing an increase in costs, would that start to be reflected in the rates that go into effect next year? Or would there, I guess what I'm saying is, would there be a year where potentially higher rates are in effect before, if the data shows that we might not want to reimburse? And I'm not sure how the data will show us usage. I'm not sure it's going to show us whether or not it was worth the cost. But how would we have a year before we could decrease rates, as the way the rate setting cycle works?
So just to make sure we're all talking about the same thing, you're talking about rates as far as premiums,
Yes,
not
that's my concern.
reimbursement amounts.
Right, I'm talking about
the
premium
effect
rates.
of the effect of the reimbursement amounts on the premium rates.
Right.
So I think, yeah, Sarah may have information on the timing of how that all plays out.
So is it okay, Senator Lyons?
Yes, please.
Okay.
Jen called on you. She's
Oh.
a higher authority every time. No, go ahead, please.
Just acknowledging I wasn't.
So we will be submitting our rates this May for the qualified health plans on the exchange for 2022. And we will be including the costs of all of these emergency provisions, mostly in rural, in the new rates. So many of the things that you have in this COVID flexibility bill are shifting costs between patients or members and their employer or whomever is paying for the rest of the premium. And so all of this will be included in those new rates.
Okay, that's something we haven't talked about. We have done away with COVID with a bunch of patient expenses, but those expenses are being paid. Doctors aren't being asked to swallow them. And so that's going to go in some rate.
But they've
Plus-
also, but remember that the CRF has covered a significant amount of this. So there's a lot of.
Sarah, I don't think
Why
to
are
the
you shaking
insurance
your
company.
head?
So all of the provisions that the Department of Financial Regulation passed requiring
Yep.
insurance to cover. So I'm thinking early refills, no deductibles for generic maintenance medications, coverage of all COVID costs, coverage of,
You're-
all of that was not included in rates last year because
Right.
the rates were done before, the COVID emergency.
Right,
But now
you're right.
included. And so all of those provisions are being extended as well, and they do have costs.
Right.
For example, the one that I do know is that eliminating the cost sharing for generic maintenance medications is about $800,000 annually.
Okay. Okay, thank you for that. So the question is, we're still on the timeline, and so trying to understand, because I think Senator Hardy's brought up a good point about the length of time that this is going on. So as I'm, if the data collection goes through 2022, and then final decisions are made December 23, that there's time built in for that decision making. Is that what I'm seeing? The whole year, January 1, 2022 until December 23. That's 2 years, but the 2-year period is a 1-year data collection, and then time left for making decisions about what's going to work going forward.
Right. I mean, I think it's the end of the sort of the claims tail that leads into
Right.
calendar year 2023, and then it's the data collection and analysis and the quality
Right.
quality analysis, the patient satisfaction review.
And the difficult part about this is the legislature begins its session in January. So to say we're going to have a decision in August isn't going to work. I mean,
Well,
I hope we're not meeting in August again. That was not fun. Go ahead, Ruth.
so I just, sorry, I'm so tired. It's hard to keep, if we did the July 1 for the codes, and we did August or October 1st to October 1st, so October 1st of 2021 to October 1st of 2022. Sarah just sent me a note that says it takes 3 months to get the data collected and analyzed. Did I understand that correctly, Sarah? So we could then have data by January, maybe February, because we want to, have a cohesive report. January or February of 2023. And then we're in the middle of a legislative session, and we could make a decision a year earlier than this draft has it right now. The other thing is, it may be that the data is so obvious or whatever that the payers and the providers and figure it all out without us muddying the waters like we're doing right now. I don't know.
Well, I think
That's
we're
what they
getting we're just asking questions, and if you have a comment, it would be helpful to make it publicly, and that would help. Because I've had the comment from someone that said, maybe we should hear from DFR, and I'm happy to do that. Maybe we can, we'll phone a friend tomorrow, or have Jen reach out to DFR and see if there's something to be offered there regarding the suggested timeline, October to October, because that's a suggestion that's been made by Senator Hardy. I don't think we can make these decisions without the expertise of DFR, frankly. So, all right, Catherine.
Just one quick thought, Chair Lyons, sorry, this struck my mind that there may be some ramp up time between the time that codes are decided and then office systems have to be upgraded, changed up, those changes integrated into education and office flows, and that may need some time and attention as well.
Yes, thank you for that. It's not just like the codes are made and then it happens. There are people who have to put it all together, and not the least of which I would think would be OPR and Board of Medical Practice providing some guidance around audio.
Yeah.
So, and perhaps the insurance companies giving some input on that as well. So, all right, here's my suggestion. We've done a lot today. I think this has been a very good conversation. And Jen, we've identified some points that we need to fix. So my suggestion is that we come back to this again tomorrow. We have it on our agenda. And
Do you want to finish going through the language just so that you have the full
yeah,
scope
yeah.
of what's in there?
That's what I was going to say. Let's finish the language, and then we'll come back to the discussion points that we've had.
Okay, so section 4 gives the Department of Financial Regulation the authority, directs them to consider adopting, and gives them the authority to adopt, which is the language that's been used in the other COVID flexibility bills. Emergency rules to address health insurance coverage of and reimbursement for these triage calls, telephone calls used to determine whether an office visit or other service is needed. And those emergency rules would remain in effect until not later than April 1st, 2022. So again, run through the end of March 31st, which is consistent with the rest of your changes to the COVID flexibility language. This is in recognition of the fact that a lot of what is in this language, the rest of the language, is plucked from DFR's rulemaking around audio only coverage, but there's nothing left that addresses telephone triage services. So it continues DFR's emergency rulemaking authority around telephone triage. Then in section 5 is a conforming change in the existing statute on health insurance coverage for telemedicine to give this exception to the reimbursement parity if the insurer and the provider enter into a value-based contract that includes telemedicine or store and forward instead of the reference earlier to audio only telephone. Section 6 is that reimbursement parity repeal on January 1st, 2025, which obviously we can revisit if you change the timeline or if you want to make other changes. And then the act itself would take effect on passage.
Okay, yes, thank you. And I'm thinking that the more time you allow, every task takes up the time allowed for it. So, but I'm looking at that January 1st, 2025 and wondering why that is there, frankly, given that the legislature's meeting during 2024 and
Right, so it carries
yeah.
through the end of calendar and plan year 2024. So there's not a change. So the changes that would be made would begin at the beginning of 2025. So it sets it up to have the reimbursement parity repealed on January 1st, 2025. But remember, that's the end of the 2024 plan year.
Right, and so that's a question for DFR. Okay. Committee, thank you. This has been enlightening and helpful. So Jen, maybe you and I can just touch base afterwards so we're clear on where the questions are and where we've identified possible changes. We'll do that, and then
Great.
we'll come back tomorrow, and either I will have reached out to DFR or Jen or I will have reached out to DFR, or we'll see if Commissioner Pichak is available. He's or maybe Sebastian or someone in the office.
Somebody else.
Yeah. And if they're not, and we'll just try to get information that would be helpful to us from them. Okay, and everyone on the call, I greatly appreciate your work, but I also would hope that along the way, there's always positions that are taken, but I think it's really critically important that we try to bring audio only into the future of medicine. And this is an opportunity for us. We don't want to lose it. And certainly we've heard that there's a lot going on across the country about this. And I know I've heard from at least one person who said that there was a verbal or an oral
Agreement.
support for Vermont and the good work that Vermont's done, but let's hope it continues. So thank you all. But I think we're good. Senator Hooker.
Senator Lyons, I need some clarification on codes and what they involve and the
Oh,
codes that
good.
govern inpatient visits. And what does that look like so that I can compare it to what's available in audio only? So if somebody could do that for me, I would greatly
Oh,
appreciate
look
it.
at, we've got 6 minutes, Senator, and I think that's a really great conversation. So I'm reaching out to Helen. You turned your screen on, so is this something that you're interested in speaking to, and Sarah as well?
I love nothing more than coding. 6 minutes, on the
Good.
other hand, may not be within my skill set.
We did, listen, we've tried to bring codes into alignment for a long time, so go ahead.
I think perhaps the most important thing, and tell me if this is sort of the level you're looking at, is the way we're proposing to set this up is you'll have the code for the service that you as the healthcare provider have the code for the service that you provided to the patient. And that's either a CPT or HCPCS code. We don't need to worry about what that acronym means, but it means that it's standardized. To that, you can then attach modifiers for location. And we have and other things, but we have modifiers attached to them that say, well, this is a service that was provided and it was provided remotely. What we don't have is a modifier that says it was provided remotely by a telephone. And that's where the holdup is right now. On top of that, you hear us refer to, there are also telephone codes. So something like, and I believe in my previous testimony, I have an example of this with G2012. So that'd be a HCPCS code. But that's something that only happens when you're using a telephone, and the service itself is tied to a telephone. So you don't need a modifier. And that's why we have some codes where we know how they were delivered because it's inherent in the service. It is a telephone-based service. And other codes where it's parity of service, you're doing the same thing. You're just going to modify a description of what modality you used. And that's the big set, your typical office visit, for example, where we can't tell right now in the claims data which modality it was, only that it was virtual. Does that answer your question? Of course, Sarah will have lots of details as well.
I understand the idea of codes and billing for certain codes, but what's a code? I mean, what does it entail? When you talk about an inpatient visit, an in-office visit, what does that mean? What does it have to be? So that when I'm talking about a telephone audio only visit, what do I have to provide that makes it comparable to what is done on the in-office?
So interestingly, that recently changed in 2021, and I can send you a article on that. So the AMA will do trainings on that. So it involves right now, a primary element of it is the amount of medical decision-making being made and the amount of time being spent with the patient. And those are really the critical things that you were coding for, and then also just what it is that you did. And I can go back and check my previous testimony. I tried to include some examples of the actual text that goes with those code descriptions, but happy to submit some additional ones. Also, Representative Black, I believe I've held up multiple times as the expert in all things coding, including what number corresponds to what part of the body. So she is the master of all of this information.
Master of codes. Okay. Jenna Black, is that Representative Black?
Alyssa Black.
Alyssa Black, sorry. Yep. Okay. So you have another friend to reach out to, Senator. Sarah, did you want to comment as well?
I don't have detailed information about codes. I do know that they're standardized nationally, and so we're supposed to use the codes in the way that they were intended. And currently Vermont is using in-person codes for telephone calls. And so that's what's really unique about what we're doing right now. And an in-person visit has other costs to the provider included in that code value. So it's supposed to be, the cost of the building, the cost of the supplies, the cost of all, the intake room, those things are included in that. And so when we use in-person codes for telephone calls, we are not using the codes in the way they were intended.
Let me ask this question of everyone sitting here. I don't want to start World War III. I won't ask it because it's 11:59, so I'm going to hold it. but I'll probably bring it back another time. I think we're good. Senator Hooker, are you feeling okay? And
Yeah, I mean, I just have no experience with what these things, with these codes are, so it's good to have an explanation. Thank you.
yep. Yes, when you live with people who deal with these all the time, it comes as second nature, I guess. But if you don't, it's just not there, and it's very understandable. Catherine,
Just an additional thought on codes, Senator Hooker, from a quality perspective, that's the foundation from where we'll start analysis to filter out and focus in on any particular, clinical topic or service or provider, so that we can start a quality analysis. All coding is the foundation of being able to understand our performance. So we're big fans of accurate coding and the standardized coding systems.
and that makes sense. Thank you. Okay, committee, thank you. This has been a very helpful meeting. And I'll thank everyone else who's been very patient and stayed online with us. We'll get back to it tomorrow. So take care.